Good morning. I am Tisa Vorse. I'm with the Michigan Department of Health and Human Services Asthma Program, and I'd also like to welcome you to the second of our two 2020 sharing times. I owe a big thank you to our planning committee and to Hurley Medical Center, who has, again, partnered with us to provide our NCEUs. I do miss seeing all of you in person, and I know that we missed some networking by meeting virtually, but I'm hoping you'll get a lot of great information today that will help you in your work as an asthma educator. So last week, the graphic was ripples touching each other, and today it's Tinker Toys because we are at distance, but we can still support each other to provide a big impact with our patients and our clients and with each other. Want to remind you to please fill out the evaluation survey. There's more on that in the meeting information that I sent out. You'll also see a link to the evaluation in the chat box near the end of the meeting. In the interest of time, I won't be making any lengthy introductions. We provided more information about our speakers in the meeting information that I sent earlier. This webinar is being recorded and will be posted on getasthmahelp.org, and you'll see the announcement for that. Also, the recording of the previous sharing time will also be available very soon. So let's get started. Corey went over the how to ask questions, and we've got that slide up again. This is how we'd like you to do questions, but any way that you get the questions to us, we will try and respond. So let's get started. Our first speaker today is Tiffany Doolittle. Tiffany's a certified asthma educator who provides asthma education at Ingham Health Plan Corporation. She has a lot of experience working with folks on smoking cessation, and today she's going to share her expertise with us. Thank you, Tiffany, and go ahead.
Hi, everybody. Thank you all for attending the second session of Asthma Sharing Day. I wish we were all together in person, but I'm thankful that we get together, even though if it's through a screen. So let's get started. We're starting out with a poll question. All right, this question is, which superpower would you like to have? Mind reading, invisibility, teleportation, flying, or I already have a superpower, I help people quit smoking. I'll give it a few more seconds to get your answers in. All right, 3, 2, 1. All right, looks like we have a wide variety of superpowers people wish they could have. That's great. How interesting would the world be if we had all these superpowers? Next. All right, as Tisa said, I'm an asthma educator and a nurse. I work with the MATCH asthma program in Ingham County. MATCH stands for Managing Asthma Through Case Management in Homes. I also have experience in tobacco dependence treatment, which gives me that superpower in the poll question. It's my hope that for those attending the session today, these two objectives will be met. Discuss best practice techniques, incorporating tobacco cessation into asthma education, and review current tobacco cessation tools and resources available to asthma educators. Please note that even though we will be talking about asthma or about tobacco cessation in the context of the asthma educator, gold nuggets can be gleaned and used in other disciplines, whether you're a doctor, a nurse practitioner, a respiratory therapist, a social worker, a relative, or a friend. I'm hopeful that this session will help you to help people who use any addictive nicotine product, especially cigarettes. I'm also hopeful that children with asthma who are exposed to secondhand smoke can be helped as well. Please type any questions that you have along the way in the question and answer, and I'll look at those at the end. You'll have a chance to ask more questions at the end as well. Next. All right, we have our second poll question. This is, I encounter somebody who uses tobacco or nicotine products more than once a day, every day, once a week, once a month, or never. Okay, let's see what the results are. Okay, it looks like there are some people that encounter people once a day, but sometimes it's more infrequent. I just want to point out that every time you encounter somebody that uses tobacco or nicotine products, you have a great opportunity to offer encouragement to quit and provide direction and helpful resources. Next. In the time before COVID-19, I provided in-home asthma education services with adults and families with children who have uncontrolled asthma or have a new asthma diagnosis. Currently, due to COVID-19, I'm still able to provide asthma education services, but match visits are over the phone and via video calls now. The big goals of asthma education remain the same and can be summed up into 3 areas: reaching medication adherence goals, reaching asthma trigger management goals, and overall asthma control if possible. Next. The approach does matter. The interactions with families I serve are based on the mutual expert model, and this helps support shared decision-making. This approach is something that I've been using for many years and learned the approach when I was in training to be a tobacco dependence treatment specialist. The approach acknowledges that a person with asthma or the child with asthma, along with their family, are experts in their asthma. As an asthma educator, I'm the expert in the asthma education. Together, we can work together to meet mutual goals. Approaching people with this framework from the start is helpful in moving along behavior change. Motivational interviewing techniques are folded into this approach and also move along their behavior change. The Match Asthma program consists of approximately 6 visit lessons on the topics that include asthma basics, anatomy and physiology, asthma triggers, managing asthma triggers, asthma medications, understanding the asthma action plan, and working with the asthma team, including working with schools and childcare providers. The last visit is a review of all the material and answering any questions that the individual or the family might have. Next. The match phone call visits and video calls are working, like I said, but there's a huge benefit to doing home visits. There's an opportunity to really observe the environment and see the surroundings in which the family lives. There are times that asthma triggers are identified prior to even saying hello to the family. Maybe it's just me, but I believe I do have a sensitive sniffer. My nose identifies things like scented devices plugged into outlets, the powdery sprinkles that freshen carpet, candles that have been burning, smelly incense, musty mildew, wet dogs, and tobacco smoke. All of these can be asthma triggers. There are 2 types of asthma triggers, and they are called allergens and irritants. This session focuses on the lung irritant, tobacco smoke. Next. Let's talk tobacco smoke. In contrast to allergens that produce an IgE response, irritants do not, but they produce the same results. Irritant triggers are also referred to as non-allergic triggers. Asthmatics respond to triggers because they have sensitive airways that are twitchy. This sensitivity causes the airways to tighten, mucus to be produced, and with prolonged asthma trigger exposure, the inside of the airways begin to swell. These 3 characteristics of asthma, tightness, mucus, and swelling, cause airways to narrow and breathing to become difficult. Secondhand smoke is also referred to as environmental tobacco smoke. This refers to the smoke that's released in the air when the smoker exhales or the smoke that comes off the tip of a burning cigarette. Children are at high risk of lung damage and illness from secondhand smoke or the inhaled smoke. Studies show that older children whose parents smoke get sick more often. Their lungs grow less than children who do not breathe secondhand smoke. They also get more bronchitis and pneumonia. Wheezing and coughing are more common in children who breathe secondhand smoke. Secondhand smoke can trigger an asthma attack in a child, and children with asthma who are around secondhand smoke have worse and more frequent asthma attacks. More than 40% of children who go to the emergency room for asthma live with smokers. Children whose parents smoke around them get more ear infections. They have fluid in their ears more often, and they also have more operations to put ear tubes for drainage. And then I'd like to talk about third-hand smoke a little bit. Third-hand smoke is a residue from tobacco smoke. When a cigarette is smoked, chemicals in the smoke stick to surfaces and dust for months after the smoke is gone. You might see on walls of smokers, there's a yellow residue. That's the third-hand smoke. The chemicals in the residue react with the pollutant air, like ozone, to create harmful particles you can easily inhale. Third-hand smoke particles are extremely tiny, easily making their way into the lungs. These particles can stick to the skin and clothing. Adults and children then breathe in the residue or absorb it through their skin or mouth. If secondhand and third-hand smoke can be eliminated from a child's environment, health will improve, asthma control should improve significantly, and a simple intervention can have a significant impact for both the child with asthma and the smoker. Next. Okay, we have our third poll question. The time that I have to provide a tobacco cessation intervention. I don't have time, a few minutes, 30 minutes or less, greater than 30 minutes, or non-applicable. All right. Give it just a few more seconds here. 3, 2, 1. All right. It looks like a lot of people have just a few minutes. I appreciate you answering that question. It looks like some people have some greater time, and then there's people that don't have an opportunity really, or it's not applicable to their work. So, all right, let's go on to the next slide. So best practice work in tobacco comes from the book, Treating Tobacco Use and Dependence. This book has provided strategies and recommendations to assist clinicians since 1996. The Public Health Service-sponsored Clinical Practice Guideline Update encourages every clinician, health plan, and healthcare institution to make treating tobacco dependence a top priority during visits. Patients should be asked 2 key questions. Do you smoke? And do you want to quit? Followed by the recommendations in the guideline. So ask is the first one. Identify all tobacco users every visit. Advise, strongly urge all tobacco users to quit. Assess, determine willingness to make a quit attempt. Refer, provide resources to refer to the quit smoking program. Assist, aid a client in quitting. Arrange, and follow-up contact. Tobacco dependence is considered a chronic disease and often requires a repeated intervention and multiple attempts to quit. Effective treatments exist, and if accessed, they can significantly increase the rates of long-term abstinence. Next. A quick tobacco cessation intervention has some key components to remember. Like before, you want to ask your families on intake about their tobacco use, or if anyone that lives with them smokes cigarettes. Provide current tobacco users with information about why it's important to quit and how a quit line can help. Encourage tobacco users to utilize medications and counseling to support their quit. Cold turkey quitters have a 10% chance of being successful, and with a combination of medications and counseling, that increases their rate to about 50% chance to quit. Keep quitting should be encouraged. The average number of quit attempts before someone actually quits is 7. Next. When you assess and ask if the client is willing to quit, you'll get 2 responses. The first one is, yes, I'm willing to quit. And the other one is, I'm unwilling to quit at this time. This can be a difficult question to answer for a smoker, especially if they have never been asked that question before. I don't know might be another response you might get, asking them to consider quitting if they're not ready right now. And you can always ask if you can provide them with some information on quitting. That information may help provide interest, confidence, and readiness to quit. The next visit, you can follow up with them and assess again their willingness to quit. If an individual is willing to quit, this is a really big deal. I actually get super excited when a client shares that they're willing to quit. Many times, shame is associated with quitting, and you might be the first person who has shown support for their quit attempt. Let the soon-to-be non-smoker know that this is one of the best things that they can not only do for their child with asthma, but for themselves. Providing resources and tips to get them started with their quit right then and there can be very helpful. I carry a quit smoking packet in my work bag to give when the opportunity arises. Now that the match visits are over the phone or video call, I'll send the quit smoking packet via email or snail mail if needed. Next. If you don't have any materials to provide at your visit, here's some tips to get started quitting that you can provide. So, number one is decrease to 5 cigarettes a day. Some people smoke a pack or even a pack and a half. Some people say they smoke 10 cigarettes a day. If you can ask them to cut down to 5 cigarettes a day, it's enough to avoid going into nicotine withdrawal. And it would set them up well to start nicotine replacement therapy when they contact their doctor or get NRT over the counter. So the second one is think about a good quit date. Today might not be a good day for them to quit. They might be willing to quit, but they have to think about when a good quit day would be. Being prepared is important, and developing a support system is important. So the quit date might be surrounded about those other options. Drink a lot of water. If you drink a lot of water, it decreases the cravings. Encourage to get in touch with the quit line. 1-800-QUIT-NOW is just an easy number to remember and a great resource. There's also tech support and websites that help quitting, and they could Google just quit smoking options, and lots of options will come up, and we'll discuss those more later. Sometimes as well, people are not willing to call the quit line right away. So just simply telling them, you don't have to be quit to call the quit line. You can be thinking about quitting and call the quit line. The counselors will assist with more quit strategies and encourage and support them. You can be weeks away from quitting, but just encourage them to make that call. Think about what they want to replace their smoking addiction with. Lots of time is spent thinking about smoking. Lots of time is spent smoking. And lots of time is spent planning on how you're going to get the cigarettes, going to the store. And some people roll their own with loose leaf tobacco and papers. Lots of time is spent doing that as well. So things people can replace smoking with includes just about anything. Encourage them to think about a new favorite hobby, going to the park with the kids, games with the kids, journaling, taking walks, getting in shape, going to the YMCA. One dad that I work with lost 30 pounds when he quit because he replaced his addiction with jogging on the treadmill. Another option could be looking up recipes and cooking great meals, because the food will taste better also, because smoking impacts the ability to taste and smell. And the last one is encourage them to think about reasons to quit for their health, and maybe consider the money that they could save, not to mention if their child has asthma, how much that will help their health as well. Next. Everybody comes up with the reason to quit that motivates them most. A child with asthma would seem like a reason to quit, but sometimes it's not. Maybe the parent thinks that smoking does not cause the child's asthma to become worse. Parents that do report that they are unwilling to quit many times have reasons why that it's not a good option right now. So this story is about Rose, and it's helpful in understanding why some parents may not be willing to quit. I've encountered many stories working with families. Rose's case was highlighted in AMA's Journal of Ethics, Illuminating the Art of Medicine article titled, "Is Parental Smoking Neglect of an Asthmatic Child?" The link to the article should be placed in the chat for your reference. The next several slides will go over parts of the article. Next. All right, we're going to unpack this case. So Rose was brought to the local emergency department by her mother. And we find that Rose is an asthmatic child. She's coughing, she's being carried, she's having trouble breathing, she smells like smoke, and she's been admitted multiple times. Moving over to Trisha, she's a third-year medical student. She smells the smoke and asks the mom, "Have you tried quitting?" She hears the mom say that smoking's not the cause of the child's asthma problem. And she goes to the attending, highlighting signs of neglect, asking if this would be grounds to notify CPS, medical neglect. And the mom's response is she's hysterical when she comes in with the child, flagging down the nurse in the emergency room. She smells like smoke. She's upset with Trisha by the scowl. And she says smoking's not the problem. She smokes with the windows open, cares for her daughter. She shows that she cares for her daughter by rubbing soothing circles on her back. And asthma is the reason they're in the ER. And then prior ER visits, it is noted that the mom was counseled to quit smoking in the medical record. Next. So neglect is highlighted in the article as well. And it's defined as the failure to satisfy a child's basic needs, not only for those for food, clothing, and shelter, but those for approximate and timely medical care and shielding from exposure to family violence and substance abuse in the home, among other things. Implicit in these is the classification of lack of parental supervision or failure to protect a child from harm as neglect. In considering whether Rose's mother's behavior is neglectful, we must ask whether Rose's asthma exacerbations can be tied solely to the mother's smoking or whether other factors could contribute to the problem, such as allergens or other environmental triggers are present. Next. Also in the article, the Children and Families Safe Act of 2003 is highlighted, and that states, the Children and Families Safe Act of 2003 defines a child's maltreatment as any recent act or failure to act on part of the parent or caregiver, which results in death, serious physical, emotional harm, sexual abuse, or exploitation, or an act of failure to act which presents an imminent risk of serious harm. So we must consider, is the effect of Rose's mother's smoking on her health, safety, and well-being? Next. All right. So is secondhand smoke exposure neglect? The article illustrates that studies show secondhand smoke exposure can exacerbate or cause children to develop asthma. The duration of secondhand smoke exposure can incite asthma. There's a 33% higher incidence of asthma among those exposed to secondhand smoke. There might be a 28 to 70% increased risk and incidence of wheezing due to secondhand smoke. And then the anti-secondhand smoke legislation has resulted in the overall decrease of asthma-related visits to the local ERs. And then the U.S. Department of Health and Human Services, they indicate a couple things, that asthmatic children exposed to secondhand smoke equal exposure to hazard, which equals inadequate supervision and neglect. Health and Human Services considers secondhand smoke in the same category as poisons, loaded guns, unsanitary living conditions, and lack of vehicle safety restraints. And failure to follow physicians' instructions can be defined as medical neglect according to some state laws. And family court and custody decisions may be made on the evidence of secondhand smoke exposure. So I wanted to do a poll question here, but I decided not to. But just think to yourself, is reporting this family to CPS warranted? I kind of think yes, and a 3200 form may be needed. But there's also some other considerations that we need to chew on. Next. Some interventions that were noted in the article include, number one, remember we're in a partnership with the families that we care for. Two, provide families with the tools that they need to keep their children healthy. Three, Assume that the parents are doing what they feel is best for their children. Or, if what they are doing does not appear to be adequate care, then perhaps we have not done our best to educate them or give them the tools to be successful. 5, in a non-critical and helpful manner, record what we have done so other providers have an accurate record of the situation. In the article, it also mentioned that in reporting to CPS, there's the possibility of the family not seeking medical care and causing a greater risk as well. But also from a clinician or a healthcare worker's point of view, a lot of resources can be provided to that family if you access CPS. The families don't tend to look at it that way, though. I'm not saying that CPS shouldn't be called. In many cases, they should be called. But you just have to weigh that. And then especially ask ourselves, have we done our best to educate them or give them the tools to be successful? So in addition to the interventions that we just went through, if a parent is still unwilling to quit, stating that the smoke doesn't bother their child, it's important to let them know that you smell smoke. People who smoke typically don't know they smell smoky or that their home smells smoky. And an interesting fact is 48 hours after quitting, the ability to smell improves. The nerve endings that are damaged by smoking begin to regrow, improving the sense of smell. So that means that a parent that smokes thinks that if they smoke away from their child, when the child's not home, outside, or in another room, or with the windows down in the car, they really believe that the smoke isn't impacting their child because they don't smell the smoke in the environment and on their clothes and in their hair. If I let a parent know the smoke bothers me, it is likely to bother the child. Smoke in any form is an asthma trigger. The mutual goal with the parent turns into helping eliminate secondhand smoke from the child's environment. Smoking outside using a smoking jacket is encouraged. This reduces harm, but does not eliminate the trigger. Personally, and this may sound extreme, but I do notify the parent that showering may be the only way to get the asthma triggers off of them. And that's a lot of work to shower after every cigarette. Are they sure they don't want to quit? If there's time to go a little deeper, and when it's appropriate, in visiting with the parent or the individual that's a smoker, I ask permission if they would consider sharing their smoking story. Sometimes they say yes, and sometimes they say no. If they say yes, you can emphasize that you're asking because you care and there won't be any judgment. If they have difficulty starting to tell their story, you can ask, when did you start smoking? At what age? How they obtain their cigarettes? How many cigarettes do they smoke? What brand of cigarettes they smoke? Have they ever cut back and quit? Do they know of somebody close to them that has quit? Many times you'll gain more information than anticipated to be able to help them. Additional needs may be identified and opportunities to refer to resources such as food resources. They may not have enough money to pay for food because cigarettes are expensive. They may admit to having anxiety or depression, and this is why they're self-medicating. And a referral to a counselor for mental health support would be helpful. Or sometimes a history of abuse or neglect comes out. And again, a mental health specialist referral would be appropriate. An interesting fact, the average age of people who start smoking is 11. If they respond no and they don't want to tell their smoking story, ask them if they would consider sharing at the next visit. Or if they say no, ask if they would consider calling the quit line to find out more about quitting smoking, or if you could bring them a packet of information the next time you visit, or email them the information. Next. When needed, we have the power to do these two things: provide parents with adequate, timely, and easily understandable education, and give parents palatable options for decreasing their children's smoke exposure. I do have another story, and this mom gave me permission to share. I provided match asthma visit to a young mom and her daughter. The mom was able to keep her daughter out of the ER and hospital, being very consistent with her controller medications, and giving her daughter a lot of albuterol. The home on initial visit was smoky. After discussing asthma triggers, notifying her that I smelled smoke in the apartment, she agreed to smoke outside. She did just that, and the next time I visited, there was just a more old, musty smoke smell. Support and encouragement was given for this noted improvement of the indoor air quality. The next time I visited, I discovered that the daughter had been in the hospital, experienced a significant respiratory episode, was in ICU, and mom was visibly shooken up. She shared that before she took her daughter to the ER, she came inside from smoking a cigarette, and her daughter snuggled with her on the couch. After that, the wheezing started, and difficulty breathing was obvious, and the rescue medicine did not help. This mom understood that her cigarette smoke in her hair and on her clothes triggered her daughter's asthma significantly, and it sent her daughter to the hospital with a life-threatening asthma attack. She quit smoking cigarettes on the spot. When she and her daughter returned home from the hospital several days later, with her sense of smell alive, she smelled the musty cigarette smoke. She was disgusted and asked me what she could do about it. Her daughter was okay, playing and breathing easy, so mom and I celebrated the daughter's recovery, but also we celebrated her quit smoking. I met her where she was that day. I spent my hour visit with her washing walls, cleaning, taking down curtains, bagging up blankets and other household washables to take to the laundromat. After our visit, she went out and rented a steam cleaner for the carpets and the furniture. I provided her with more quit smoking tips and resources, encouraged her to call her primary care doctor, and discuss the best options for medication and NRT to assist with her quit, and encouraged her to call the quit line. At the next visit, not only did this young mom report that her daughter's asthma was much more under control, she felt better and could breathe easier. She was happy to have energy to run and play with her daughter. And with the money that she saved, not having to buy cigarettes, the family went on a water park vacation out of town. Next. So this is a good start packet, and I sent this to you. Tisa sent it out to everybody with this invite for today. It includes just some resources that have been found very helpful in helping people get started, especially if they don't know how to get started. The first one is the benefits of quitting smoking. So looking through the benefits page is a way to build confidence in quitting by putting more reasons behind the quit attempt. According to the Surgeon General, quitting smoking is the single most important step a smoker can take to improve the length and quality of his or her life. As soon as someone quits, the body begins to repair the damage caused by smoking. I usually just highlight a few benefits and ask at the next visit if any of the benefits stood out to them. A broken addiction cycle is a biggie, along with better vision, a clean mouth, clear skin, decreased heart risk. The risk of a heart attack declines within 24 hours after quitting. Quitting smoking can give you thin blood. You have less risk of blood clots and stroke. And something really interesting is your cilia in your respiratory tract, it comes alive again after a few days or up to a week after the smoker quits. So those cilia are little hairs in the respiratory tract, and it helps with bringing the tar up, maybe that was stuck down in the lungs. It's also important that cilia is to fight off colds and infection. They have a decreased risk of cancer of the lung and bladder, and people that quit smoking, healing is improved as well. Some doctors won't even do surgery unless people have quit smoking prior to the surgery. And also the immune system becomes stronger. Then what to do is the second one listed up there. That's a motivational page to reference back to or to develop at the beginning of a quit smoke attempt. And it's meant for encouragement. Or if a slip happens, if somebody starts smoking again, they can go back to that and review the things that the reason that they're quitting, to keep on quitting. Maybe they can list out their support people on there. And every person has their personal reasons for quitting. Putting that reason would be the best thing to put in one of those empty circles. They might want to live longer. That might be their reason, or they might want to save money. And this is interesting too. It's expensive to smoke cigarettes. In some places, a pack of cigarettes costs more than $10, and prices keep rising. In Michigan, the average cost of cigarettes is about $7 to $8 a pack. And so if there's 20 cigarettes in the pack and people are spending $7, we'll say, a day on smoking, they will be spending $210 for the month, $2,555 for the year. At the 10-year mark, they'll have spent $38,253. And after 20 years, it's going to be $102,181. Asking them to figure out how much they will be saving and what they could do with that money instead puts encouragement and hope in their hearts. A client that I worked with in the past was able to afford to buy a car by quitting. And another family, when both the mom and the dad quit, they were able to afford a house. Some families plan vacations with the money that they're able to save. So do the math with them. It can be really powerful. Other great reminders on this page are just getting encouragement and support. Who are their support people? And then to keep quitting or set a new quit date if there's a slip, and then to take longer breaks between cigarettes. The third one is the 6Ds. And these are just 6 items that can help you get through a craving, basically. So the first one's delay. Wait 5 minutes for the urge to go away. Distract yourself. Talk to a friend. Give them a call. Drink some water. Try for 8 ounces of water a day. Drinking more water decreases cravings. Deep breathing. The act of breathing in, inhaling in and out when you puff on a cigarette, just that is relaxing. So they can do the breathing in, take a deep breath in and out several times, and it's relaxing. That's an important reminder. And do something different. Go for a walk. And then just don't give up. The next one on the list, number 4, is what's in a cigarette. This is one that I usually ask permission to go over. It can be really scary to look up at. And, some people don't want to know what's in a cigarette. It's just too hard and too scary. There's an estimated 7,000 chemicals in a cigarette, and 70 of those chemicals cause cancer. You can look that over and see and do some more research yourself about what's in cigarettes. It's kind of a toxic soup, to be honest. And, they put things in there that are really damaging to the health. Something encouraging is within 20 minutes. And this is just amazing to me. When I first learned about helping people quit smoking, this is the thing that really gets people excited because so many things happen right away when you quit smoking. Within 20 minutes after quitting, your heart rate drops. 12 hours after quitting, carbon monoxide levels in your blood drops to normal. And that's important because basically carbon monoxide, your body picks up carbon monoxide on red blood cells more readily than it does oxygen. So people have a really high level of carbon monoxide in their body. And then their body has to produce more blood cells. So you have more blood cells in your body trying to make up for the lack of oxygen. And that's when the clumping can happen and you're more prone to blood clots. So yeah, within 12 hours, that's amazing. The carbon monoxide levels drop to normal. Within 2 to 3 months after quitting, your heart attack risk begins to drop. Lung function begins to improve. And at 1 to 9 months after 1 to 9 months after quitting, coughing and shortness of breath decrease. And that's something that a lot of clients say that they experience is going upstairs is a lot easier about 2 to 4 weeks after they quit. 1 year after quitting, the risk of coronary heart disease is half that of a smoker's. 10 years after quitting, lung cancer and death rate about half that of a smoker's. And risk of cancer of the mouth, throat, esophagus, bladder, kidney, and pancreas decreases. And 15 years after quitting, the risk of coronary heart disease is back to that of a non-smoker. So the quit resources, you can look through those. All of them are excellent. I did update some of them. Some of the links didn't work on the MDHHS website. So I updated all those. Hopefully those are very helpful. And some of the quit resources are for different groups of people, teens, Native Americans, all different resources on there. There's something for everybody on there. And then the smoking cessation options, that's the over-the-counter prescription smoking options. That is a very helpful tool. And the reason why it's so helpful is because it provides the pros and cons, the proper use and dosing recommendations of the NRT or the medications. And this is something that should be talked about with their doctor, but it's kind of nice having something that they can go in and be thinking about what option might work best for them. So most people give up on nicotine replacement therapy because it's not used properly or the dosage is not adequate. Most insurances do cover NRT, and some of the quit lines offer free. So it's good to keep that as a thought in the back of your mind. Just remember, when a person has a nicotine addiction, they fight a brain war of will and addiction. They have reasons to quit smoking, but the screaming from the nicotine receptors in their brain usually wins. This is why it's important to direct the smoker to their doctor for a prescription for quit smoking medication and nicotine replacement therapy. With medication and nicotine replacement therapy on board, the screaming will turn into a whisper and their will to not have a cigarette will overcome. The psychological component of smoking needs to be addressed as well, and that's changing behaviors that trigger having a cigarette. So that's why it's important that getting in touch with a quit line, working with a counselor is helpful. Like I said before, medication and counseling is the most successful way to quit smoking. Remember, a 50% better chance. Next. At the beginning of this presentation, I mentioned that the Match Asthma program is 6 visits. At each visit, smoking is addressed, and if there's a smoker, or if the child is exposed to a secondhand smoke. The initial visit includes asking if there's a smoker in the home or if the child is exposed to secondhand smoke. At the second visit, we discuss common asthma triggers, including any kind of smoke. But something interesting is that the children identify pictures of the triggers that bother them, and parents add to what triggers a child's asthma. Many small children identify the picture of an ashtray with a burning cigarette in it as a trigger that makes their asthma worse, even if the parent doesn't bring it up as a trigger. If mom and dad don't live together, sometimes the child says the smoke bothers them at dad's house, or it could be at grandma's house or at a friend's house. If it is dad, this provides a great opportunity to ask mom if dad would like to obtain asthma materials or quit smoking information. At times, I have gone to both mom and dad's house to provide asthma information and education and do an in-home asthma trigger assessment, and have provided quit smoking information and resources. The in-home asthma trigger assessment is a tool. It assesses, targets, and reduces triggers to improve the indoor air quality and the asthma outcomes. The tool provides a score indicating great, good, fair, needs improvement, or really needs improvement of the home. So in that tool, these questions are about smoking. Does anybody smoke inside? And they get a score based on if they say not at all, once a month, once per week, once per day or more than once per day? Or does anyone smoke outside? And they get the same scoring system for that one. And then there's another question: do people who smoke outside wear a smoking jacket? And then the third visit topic is managing asthma triggers. In-home asthma trigger improvement plan in response to the assessment happens at that third visit. The family and asthma educator develop the plan together. And the asthma trigger recommendations in that include, if smoking's inside, we note smoking is a major asthma trigger. Other asthma improvements will not be possible if there's smoking in the house. Smoke outside only with the doors and windows closed and wear a smoking jacket. Talk to your doctor to try to quit. Medicaid covers most of those quit smoking supports. And if outside smoking, the recommendation is you can bring smoke inside on your clothes and it is an asthma trigger. Wear the smoking jacket, a coat you only use when you smoke and that you take off before entering the home. When smoking outside, close windows and doors, and do not smoke in enclosed porches, and make your car smoke-free. So there's considerations for multi-unit apartments as well. And because sometimes there's smokers in the apartment complex and they smoke in the hallways or under the windows of an asthmatic child's bedroom. Occasionally, there's tobacco smoke coming through the apartment heating and cooling vents from other apartments. Part of the asthma trigger improvement plan may be to contact the landlord or the apartment complex office. I usually ask if they have a good relationship with their landlord or apartment complex office, and if they would like to call or talk to them about the smoke issue. If the parent doesn't feel comfortable with a phone call, I ask if I can assist them with writing a letter. Usually the letter is very well received, encouraging the landlord's assistance with a child's asthma trigger management plan. I've seen landlords create flyers and put them up on the doors in the hallways, stating that smoking is not allowed in the hallways. Another tip that can be helpful, if there's a gap under the apartment door to the child's apartment, the parent's apartment, where smoke is coming in from, I recommend rolling up a blanket or a towel and putting it along the crack under the door. Encouraging apartment complex to become smoke-free is important. In Michigan, non-smokers with serious breathing disabilities or smoke allergies have legal protection under the Americans with Disabilities Act and the Fair Housing Act. Some Michigan counties and localities have laws that prohibit smoking in common areas of apartment buildings, such as hallways, laundry rooms, and recreation areas. Michigan's smokefreeapartment.org website provides more information for landlords and tenants about becoming a smoke-free apartment. The fourth match asthma visit covers medications, but this is a good opportunity to ask if the smoker in the home had a chance to look over the quit packet and if any improvements were made regarding the in-home asthma trigger improvement plan. Also, I'll ask if they were able to get in touch with their doctor to get a prescription to help quit smoking. Visits 5 and 6 always provides the opportunity to ask about smoking, secondhand smoke in the environment, and provide an intervention or a referral. Each asthma education visit provides an opportunity to assist the family and the smoker moving toward quitting smoking and the cleaner indoor air goal. Next. So the key takeaways are tobacco cessation can be integrated and applied at each asthma education visit. And number 2, you have the tools. Be encouraged to provide interventions that help parents and caregivers quit smoking and eliminate smoke that triggers asthma. So, are there any questions?
Yes, thank you, T. So we did have a few questions come in that we'll address right now, and we encourage folks to continue asking and submitting any questions in that Q&A while we answer these. So the first question was, earlier you had mentioned that every time you encounter someone smoking, it is a chance to talk to them about smoking. Does this include your personal lives or specifically when you're coming for help?
I guess, let's see. every time you encounter someone smoking, is it a chance to talk to them about smoking? Does that include in our personal lives? I mean, it could be both, right? You have the tools now through this talk to help people in their personal lives, or through if they work at an office or they're an asthma educator and doing visits similar to the ones that I do. So yeah, I'd say it would be both.
Great. The next question. When people call 1-800-QUIT-NOW, are these trained people available to offer emotional support also? These are really challenging times, and some of us use it to feel better.
I think it's specifically for quitting smoking, if I'm understanding the question right. I think there's some other resources out there that are helping if people are having issues. I would say if they're quitting and they're having emotional issues, that the quit line would be a perfect place to call. Now, if the question is regarding if they're just needing emotional support, I think there's some better options out there.
Great. Thank you. The question you mentioned earlier, do you know what supports are available to homeless in Michigan that smoke?
Well, all of the resources that are on the resource page are available to homeless people. It depends on what kind of, if they have a cell phone or if they have access to a computer, maybe at the homeless shelter, they could access those resources. There are, in a lot of the homeless shelters, there's counselors and there's people that can provide some information and connections to resources as well to get help. I do know that in Lansing, a couple of the homeless shelters have clinics associated with them too, that they could go to providers to get help and support.
Great. And do you discuss any other smoke substance? How much does marijuana trigger asthma?
It does. So marijuana is a irritant to the lungs. So I basically give the same kind of advice I would to somebody who's smoking tobacco, that it is an irritant and it really should be avoided, especially if people or children have asthma.
Great. And it looks like Suzanne is offering some assistance in the chat as well. There was another question in the chat from Amanda. She's looking for the home asthma trigger assessment model. Would you be able to share that link?
That is in the resources that I provided to, I believe Tisa sent it in the invitation. So there's a list to that too. And you can type in, it's through ClearCorps, ClearCorps is the company in Detroit that developed the model. And there isn't any licensing on it that I know of. Anybody can use it, and it's simply designed to help asthmatics and increase the or make the air quality better in the homes.
Great. We have one more question here. What additional trainings or supports are available to asthma educators, specifically when we are helping a parent with smoking cessation and the child with asthma?
I guess any of the supports that are here in this training, I am not sure if there's any additional support. I know that there's a section in the asthma. Oh, I have it right here, I think. Oh, where is it? I apologize. It's the asthma educator training book. There's quite a bit of information in there. One thing I did notice about that section when I read through it is that there's not a lot about helping people quit smoking in that. So I think this is an area that could be developed. And I mean, there could be other trainings developed to help asthma educators. So I think it's a field out there that if people wanted to create more trainings, that it would be very helpful. I'm not aware of any other trainings that can help asthma educators with tobacco cessation.
Oh, thank you, Tiffany. That was really helpful. And, the last question about are there additional trainings or supports, it really highlights the fact that the information that you shared this morning was really needed and really helpful. So thanks for that. Our final speaker today is Dr. Njira Lugogo. She's a pulmonologist from the University of Michigan, and she presented last year, if you attended in person last year at Sharing Day, and was so well received last year. We decided to have her back by popular demand, and she's going to give us some information today on how to implement the 2020 GINA guidelines. So thank you, Dr. Lugogo, and take it away.
Thank you so much. I hope everyone can hear me pretty well. I'm working here at the hospital. So today we're going to talk about implementing the GINA 2020 guidelines, and at the very end I added a segment on COVID and asthma and what we know, which I think is a rather timely topic that we should consider at this point. My disclosures are listed on this slide here. The objectives of the talk today are to discuss the approach to the management of mild asthma and how to personalize asthma management, to discuss asthma phenotypes and biologic therapies in severe asthma, and then lastly, to review the GINA strategy, COVID-19, and asthma recommendations. Asthma is actually quite a common disease. 25 million people in the US suffer from asthma, which is 1 in 13 people and 7.7% of adults. There are disparities in terms of asthma prevalence, and you can see that female patients, African Americans, Puerto Ricans, and patients that are living less than 100% of the federal poverty level tend to have high asthma prevalence. There are disparities with regards to asthma outcomes, and I'm sure you've seen a lot of information about disparities in health outcomes, given that the pandemic has highlighted that as well. You can see here that with regards to asthma, African American and Puerto Rican patients are more likely to die of asthma and also more likely to be admitted to the hospital. There are many factors that likely play into this. Some are socioeconomic, some may be lack of access to care or inadequate care, even for those people who access care, not receiving proper patient education, and also lack of adequate insurance, amongst other things. So what is asthma? Those of you who were there last year have seen this slide. Basically, previously we described asthma as a chronic disease characterized by recurrent episodes of wheezing, shortness of breath, and cough secondary to reversible airflow obstruction. And so the key characteristics of asthma are bronchial hyperresponsiveness and airway inflammation. We now understand that asthma is a complex disorder that has many distinct pathophysiologic mechanisms contributing to the clinical signs and symptoms that you would see when you're taking care of these patients on a regular basis. The pathology of asthma is highlighted in this slide here. On the left is a normal subject, and you can see that the airway epithelium is nice and normal. You have cilia, an intact epithelium, not much goblet cell hyperplasia. Underneath the epithelium is the subbasement membrane, which is not thickened, and the submucosa is not infiltrated by inflammatory cells. On the other hand, mild patients have a denuded epithelium, increased goblet cells that result in mucus hypersecretion, a thickened basement membrane that's an indication of potential remodeling down the road, and infiltration of inflammatory cells into the mesenchyme. And so you can only imagine that in a severe patient, these changes would be much more accentuated. So we'll start out with mild asthma first. I think calling it mild is actually a misnomer for the disease because mild asthma is actually not a benign disease. And in this one publication here, you can see that if you take patients that had less than weekly symptoms in the previous 3 months, with which all of us would agree is a mild patient, those patients are still at risk of serious adverse events. And in this cohort, 30 to 37% of these patients had acute asthma. 16% of them had near fatal asthma, and 15 to 20% of people who die of asthma were considered mild prior to that fatal event. Exacerbations are variable, and most of these acute events are caused by triggers that patients cannot foresee in advance. For example, you develop a viral illness, you're exposed to pollen pollution, perhaps you're poorly adherent with medication, and then you suffer an acute event that results in a very poor outcome. For that reason, in 2019, changes were made to the GINA 29 strategy. And the primary premise of these changes was an understanding that after 50 years, we fully understand that asthma is no longer a disease of just bronchoconstriction. There is significant inflammation going on, and that patients with asthma that develop symptoms most likely have concomitant bronchoconstriction and inflammation. And in fact, treating patients with inhaled bronchodilators without concomitant corticosteroids is treating only part of the problem. In fact, what we do when we first diagnose patients with mild asthma, we give them the albuterol inhaler, which works very quickly. And so we reinforce the belief that the way you treat asthma is to relieve symptoms that are occurring acutely. We also rely heavily on bronchodilators in the emergency room and hospitals, and these drugs tend to be the cheapest medications for asthma. Therefore, they're frequently used. And so what we do in this case is we develop what we call SABA over-reliance. Next. And we basically create a situation where patients begin to believe that albuterol is the central drug that they should be using, or short-acting bronchodilators are the central medication that they should be using. And you can see here from some work we did and presented at ATS this year is that exacerbations are actually not an uncommon occurrence in patients with mild asthma. In this study, we took claims data and we looked at patients that were prescribed drugs that put them in GINA categories 1 and 2. So those were the mild patients. And we were looking at claims data to determine the prevalence of exacerbations, which was either a prescription for oral corticosteroids, receiving injectable corticosteroids, going to the ER or the emergency room. You can see here 54% of people who had less than one SABA fill in a year had an exacerbation. And as you increase the number of bronchodilator inhalers the patients filled, you can see that there's still a pretty high prevalence of exacerbations between 40 and 54%. On the figure there, you can also see, that adding leukotriene antagonists and low-dose inhaled corticosteroids didn't significantly reduce the number of exacerbations. And in the lower figure, that was true even when you took patients that had a high medication possession ratio, so people who are quite adherent to their therapy. The global use of short-acting beta agonists is very high. Here you can see a publication from 2020 showing that across Europe, the use of short-acting bronchodilators is quite high. And it's important to note that using a significant amount of short-acting bronchodilators is associated with an increased risk of exacerbations and even an increased mortality when you're taking more than 12 canisters of albuterol per year. And so we really are seeing a pattern of SABA over-reliance both in the US and across the globe. In addition, the risks of adverse clinical outcomes related to how many canisters of albuterol you use. Those using greater than 3 canisters of short-acting bronchodilator, which averages out to a little under 2 puffs a day, have a higher risk of emergency room presentations. And as I mentioned just before this slide, if you get more than 12 canisters per year, you have an associated increased risk of dying from asthma. In addition to that, there is some data showing that if you frequently use short-acting bronchodilators, you have adverse effects, which include downregulation of the beta receptor, which results in decreased bronchial protection, rebound hyperresponsiveness, and a decreased bronchodilator response. In addition, there are some basic science papers that demonstrate that using large amounts of short-acting bronchodilator can result in increased allergic inflammation and eosinophilic inflammation as well. And just as a reminder, this was the treatment figure from Njira Strategy 2018. I just want to draw your focus to step 1, which was previously no controller. So we used to give all our patients with step 1 Njira disease just short-acting bronchodilators. Down in the other controller options at that time was consider low-dose inhaled corticosteroids. These patients in step 1 and 2 have mild disease. So what has changed? The first thing you have to look at when you think about Njira strategy is the core management strategy for all steps. Just as a reminder, here we are focusing on adults and adolescents 12 years and older. So the first thing we're going to do is personalize asthma management, assessing, adjusting, and reviewing response. We're going to confirm the diagnosis and figure out if there are any modifiable risk factors or comorbidities. We're going to treat those modifiable risk factors and comorbidities and put in some of those non-pharmacological strategies like tobacco cessation. I know that was the talk preceding this one, weight management and other interventions. Then you're going to really adjust the medications up and down based on this up or down stepping strategy related to the patient's individual needs. And here we are focusing on both exacerbation reduction and also control of symptoms on a regular basis. Controller therapy in this regard means treatment that's taken to prevent exacerbation. So we're really focused on exacerbation reduction because those exacerbation events are the ones that put the patients at the highest risk of both long-term lung function decline, but acutely at risk for having poor outcomes such as hospitalizations and even dying in a proportion of these patients with mild disease. Step 2 therapy there is where the patients are on daily low-dose inhaled corticosteroids or as needed low-dose inhaled corticosteroids formoterol. So now I'll take one step back and focus back on step 1. As a reminder, the patients on step 1 were previously those that were given a short-acting bronchodilator and told, use it if you need it and call me if you have any issues. Now, that is no longer recommended. There's been a dramatic change in how we are supposed to manage those patients. The recommended preferred controller now is as needed low-dose inhaled corticosteroid with a formoterol containing compound. That's quite important to note that the inhaler has to have formoterol because that has a rapid onset of action, unlike the other long-acting beta agonists. That is off-label in the US. In Europe, that kind of therapy has been used at least in the step 3 to 4 group, and it's called SMART therapy. The other option that you could employ here in the United States is to add a low-dose inhaled corticosteroids every time a short-acting beta agonist is taken. So what I've started to do in my clinic is provide patients with an extra inhaler, inhaled corticosteroids, And I basically say, every time you use albuterol, take 1 puff of this inhaled corticosteroid. It doesn't matter which one you pick. You can pick any of those, and there will be an exacerbation reduction. In addition, you could, if the patient has more daily, more frequent symptoms, you could either give them a low-dose inhaled corticosteroid or as-needed low-dose formoterol-containing compound, or use low-dose inhaled corticosteroids whenever short-acting beta-agonists are taken. The changes to step 2 were made predominantly because we are now focusing again on exacerbations. There are 2 randomized controlled trials showing reduced exacerbations compared with short-acting beta-agonist only treatment, and 3 that show similar rates or fewer exacerbations compared to maintenance inhaled corticosteroids taken on a daily basis. We are placing a high importance on preventing severe exacerbations, once again, for the reasons that I elaborated earlier. We are really placing lower importance on differences in symptom control and the inconvenience of carrying 2 inhalers. There are combined inhaled corticosteroid short-acting beta-agonist inhalers on the market in some countries. They are only approved for maintenance use. In the United States, we currently have an ongoing clinical trial looking at the impact of using ICS short-acting beta-agonist inhalers for rescue compared to short-acting beta-agonists only. And so in the future, 1 or 2 years from now, we may have some combination SABA inhaled corticosteroid options for patients. Next. Now we'll focus on step 4. We skipped step 3 because there were no changes made to step 3. The only thing you need to know about step 4 is that step 4 therapy is now only medium dose inhaled corticosteroid LABA. Step 4 no longer includes high dose inhaled corticosteroids LABA, which basically means that patients requiring high dose inhaled corticosteroid LABA are now considered GINA 5. So we want to move now to asthma phenotypes and talk about what they are and why we should care about this. A lot of you are probably familiar with this figure here that's showing what asthma phenotypes and endotypes are. As a reminder, the asthma syndrome is a conglomeration of symptoms and the presence of variable airflow obstruction. For instance, people have decreased FEV1, inflammation, the presence of exacerbations, wheezing, shortness of breath, and airway hyperresponsiveness. On the other hand, an asthma phenotype is observable characteristics that really have no direct relationship to a disease process, but they're things that you can identify in the clinic. For instance, early onset allergic asthma, that's asthma that occurs at an early age and is associated with allergic sensitization. We also have eosinophilic asthma, neutrophilic asthma, exercise-induced asthma, etc. Asthma endotypes, however, are those distinct disease entities where there's actually a direct mechanistic pathway related to that disease. Unfortunately, we do not have any clinical tools that can help us identify asthma endotypes at this point, because we can't measure those cytokines in the clinic and be able to say that an allergic person has IL-4 driven disease and an eosinophilic person has either allergic or IL-5 driven disease. And so that is the goal in the future, to be able to really get more precise in our definitions. But I would encourage all of us to really start thinking about asthma as a heterogeneous disease and trying to understand what type of underlying phenotype the patient has, because that will inform a lot of decision making about treatment. I'm going to move on to the ATS-ERS severe asthma definition here. And this is asthma that remains uncontrolled on GINA step 4 or 5 therapy, high dose ICS LABA, LTRA theophylline, or you require those therapies to prevent the loss of control, or you require systemic corticosteroids for at least half of the prior year. I think it's quite important to point out that FEV1 is really a marker of control and not a required component of the definition of severe asthma. And if I had to point out one mistake that I see quite frequently, it's that people equate normal lung function with mild disease. And so patients will come to the asthma clinic where they've had 4 to 6 exacerbations in the prior year, perhaps a hospitalization, oral corticosteroid tapers every 6 to 8 weeks. And, nobody thinks they have severe asthma because their FEV1 happens to be 83%. And so I think you really need to get away from using lung function as a definition for severe asthma and really focus on what treatment is required to either maintain asthma control, or if the patient remains uncontrolled on maximal therapy, that is a patient with severe disease. You want to have systematic ways of assessing control. I use the ACT in clinic. You can use the ACQ. You need to have some kind of questionnaire-based objective measure of poor asthma of control. You want to document the frequency of exacerbations. Patients with a hospitalization, ICU stay on mechanical ventilation are poorly controlled, as well as low lung function. So now we are going to focus on those GINA Step 5 patients. That's the group I spend almost all my life thinking about and seeing in the clinic. These are the patients on high-dose ICS LABA, and here we are really starting to hone in on the critical importance of phenotypic assessments so that you can decide if the patient is qualified to receive add-on therapy, particularly biologics. This is a group also for whom tiotropium is a good option. Now you can see here on this figure that the good old low-dose oral corticosteroids are no longer considered first-line therapy. They've been moved down into other controller options under biologic therapies. So if you have a patient on oral corticosteroids for maintenance, you really need to be thinking about whether that patient would qualify for biologics. Also, you can see that the preferred reliever is either as needed low-dose inhaled corticosteroid for formoterol-containing compounds, or you can use low-dose inhaled corticosteroids with short-acting beta agonists, or you can use as needed short-acting beta agonists, but we are really pushing those SABA monotherapy way down on the list as non-preferred controller. I'm going to briefly talk about the mechanisms of type 2 inflammation. This is going to be just a couple of quick basic science slides, which, believe it or not, I present to my patients in clinic on a regular basis. And this slide here is really trying to highlight what the predominant type 2 mechanisms are in asthma. And you'll understand why this is important when we begin to talk about biologics. So basically, the concept is that the airway epithelium is exposed to things that we inhale into our lungs. And this airway epithelium comes into contact with allergens, pollutants, microbes, glycopeptides, cigarette smoke, etc. And in certain patients, the response to these exposures causes downstream production of what we call alarmins, and that's IL-33, 25, and TSLP. And that can cause some downstream changes. We won't focus on that today, but I will say that TSLP will become much more highly talked about in the next year or so, as there is a compound in nearing the end of phase 3 that may prove to be efficacious and may come to market in the next 1 to 2 years. So probably in future talks, we'll discuss TSLP a little bit more. Today, we'll focus on the allergic pathway. Here you have inhaled allergen causing dendritic cells to present antigen to naive T cells. Those naive T cells differentiate into Th2 cells. Th2 cells produce Th2 cytokines, which are IL-4, 5, and 13. IL-4 and 13 bind what we call the IL-4 receptor. The IL-4 cytokine causes B cells to produce IgE. IgE binds mast cells, and with future exposure to allergen, there is cross-linking and mast cell degranulation. Degranulation produces Th2 cytokines as well as histamines and leukotrienes, causing a vicious cycle there of both allergic and eosinophilic inflammation. On the other hand, IL-13 is very important in airways hyperresponsiveness and goblet cell hyperplasia, which results in mucus hypersecretion. And lastly, IL-5, which causes eosinophil maturation, migration, and proliferation, is quite important in eosinophilic asthma. So here we're going to focus on the initiation of biologics. This is our focus now in that step 5 group. We are asking ourselves, who needs a biologic and when can it be initiated? So we're going to confirm that this person actually has severe asthma, that their comorbidities have been addressed. They've been educated on their inhaler. They're using it. They're adherent, and that their contributing factors have been managed. If all those things have been done, then you want to really understand what kind of phenotyping the patient has. We'll talk a little bit more about that. And then you're going to identify appropriate biologic based on the biomarkers that we'll discuss shortly. Talk to the patients and have some shared decision making about what medications they would like to use. You initiate the therapy, determine what you're going to follow a priori, and reassess it in 4 months. What type 2 biomarkers do we have available? Basically, all our biomarkers target patients with elevated type 2 inflammation. The ones that are used most frequently are blood eosinophils, and depending on the drugs, there are different thresholds that were used in phase 3 studies. The second one is exhaled nitric oxide. It's not been taken up quite as much as blood eosinophils. You require a special device. It costs probably about $20 per test. Because of poor insurance reimbursement, many people have not been using exhaled nitric oxide measurements to determine if patients have Th2 inflammation, but it is quite a useful tool. You also want to determine if people have allergy, and that's quite important. Usually you measure total IgE, and then you want to determine if there's sensitization either by doing skin prick testing or measuring specific IgE levels. We want to note that there are some limitations to these biomarkers. For instance, many of these are variable, particularly peripheral blood eosinophils, so you really want to look at least 3 measurements in the past to make sure that the patient is actually type 2 high. Now, it's pretty interesting in that type 2 high asthma is defined as the presence of one of those 3 factors. The absence of all 3 means that you have non-type 2 asthma. And so if you have a high eosinophil count of 600 on the one CBC you have, that person likely has type 2 asthma, even if their eosinophil count is low the next time you measure it. On the other hand, if you have a eosinophil count of 150, you need to be thinking, does this person have high eosinophils in the past that are maybe being masked by therapy at this time? You need to test eosinophils over time. And if you have persistent eosinophils on oral corticosteroids, or you remain symptomatic on oral corticosteroids, those patients may have more refractory type 2 inflammation. Here, it's important to remember the impact of oral steroids on eosinophils. As I mentioned, oral steroids are frequently used. They significantly impact peripheral eosinophil levels. And you can see in this publication that when you take patients with eosinophil counts of 150 in the orange bar, greater than 300 in the purple bar, and greater than 400 in the maroon colored bar there, if you take patients with high eosinophils in those 3 strata and you give them a course of oral corticosteroid, there is a significant reduction in the mean eosinophil count over time. So you really want to understand that steroids can mask eosinophilia. If you have a patient on chronic oral corticosteroids and you don't have any evidence of historical eosinophilia, you can slowly and cautiously wean the oral corticosteroids while repeating the CBC counts with every week or every 2 weeks to see if eosinophilia reemerges in that patient. To further highlight the importance of repeated measurements of eosinophil counts, you can see this publication here that we had in 2020, where you have patients that have a eosinophil counts of less than 150 on the first 2 bars. And if you started at less than 150, 70% of those people will have greater than 150 cells per microliter counts when you repeat eosinophils, and 35% will go to greater than 300. You can see the people who are greater than 300, 52% shift to less than 300, and 22% shift downwards to less than 150. So eosinophils are highly variable, and you need to really think about that. There also are diurnal variations on eosinophil counts. They are highest at about 4 o'clock in the morning. So if you're always measuring your eosinophil counts at 4 o'clock in the afternoon, and the patient is right on the threshold of having high eosinophils required for certain biologic therapies, you probably ought to repeat that testing earlier in the morning. So now we'll transition over to the biologics that we have on the market. As a reminder, the first one here is anti-IgE, omalizumab. Omalizumab is an anti-IgE antibody, and it binds free IgE. It reduces exacerbations roughly 40%, and it causes a reduction in FeNO, the exhaled nitric oxide biomarker. Blood eosinophils go down about 40%, and it changes free IgE, but actually causes an increase in total IgE, which is measured by our current IgE testing, and therefore the validity of the total IgE is affected by the drug and is no longer reliable after initiating therapy. This is some real-world evidence that was a study aimed at trying to determine if there are predictive thresholds for biomarkers that would indicate that there is a potential for an enhanced response to omalizumab. And you can see that the patients responded to omalizumab regardless of age, and also regardless of eosinophil count or exhaled nitric oxide. All the patient groups responded to omalizumab. As noted there, IL-5 targeted therapy is also effective irrespective of underlying atopic status or elevated IgE. And it's important to note that about 2/3 of patients are going to have high IgE and high eosinophils at the same time. Here we are shifting to anti-IL-5 therapy. There are 2 options. There's mepolizumab and reslizumab, which bind IL-5, preventing it from binding to the IL-5 receptor. IL-5 regulates eosinophil proliferation, differentiation, migration, and survival. Mepolizumab reduced exacerbations 53%, reslizumab 59%. One has to note that in the mepolizumab studies, the threshold for entry for eosinophils was greater than 150, and for reslizumab, it was greater than 400. These drugs cause about an 80% reduction in blood eosinophils, no changes in FeNO or IgE. These are long-term safety data from mepolizumab. First is the Cosmos trial, which was an open-label extension study, which didn't show any significant issues with regards to adverse events. You do see, however, a good response to mepolizumab in the patients who went from being on placebo to being on active drug in the open label phase, and that reduction in exacerbations was sustained throughout the treatment period. In the Columba trial, the patients were followed for an average of 3.4 years and a maximum of 4.5 years. To me, the most interesting thing about this is that when the patients initially enrolled in these studies, the mean exacerbation rate was 3.49 per year. In the active trial, the DREAM study, you can see that the patients on mepolizumab had on average 1 exacerbation per year, and the placebo patients went down to 2.18 exacerbations per year, which indicates that there is a placebo effect from being followed in those clinical trials, getting additional attention, and etc. And it is something that's well recognized in many asthma trials. Now, when the patients went off treatment, the patients who are on mepolizumab went off treatment, you can see a slight rebound in the number of exacerbations, but it's nowhere near as high as the number of exacerbations they had when they initially entered the study. Reinitiation of mepolizumab then reduces exacerbations to on average 0.71 for the entire group, and that's sustained up to 156 weeks. So there is durability of exacerbation reduction for years after initiation of therapy. We're going to transition to anti-IL-5 receptor alpha. That's benralizumab. That blocks the anti-IL-5 receptor. It blocks the IL-5 receptor and causes near total depletion of blood eosinophils with no change in exhaled nitric oxide and IgE. Here you see that in patients with greater than 300 eosinophils, the reduction in exacerbations is more pronounced. 51% in Sirocco, which was a more severe group, 28% in Colima, which included moderate asthma patients. And in the less than 300 eosinophil category, the reduction in exacerbation still exists, but it's less striking. And this is important because you want to pick the best responders to your drug when you're deciding which biologic to use. This study here really started to hone in on, well, are biomarkers the only important thing when you're trying to choose therapy for patients? And what they noted here is that clinical features are actually quite important as well at predicting response to treatment. And this was a post hoc analysis of a study that looked at the effect of benralizumab on annualized exacerbation rate. And you can see the clinical features associated with improved or enhanced response to exacerbations include oral steroids, nasal polyps, a low pre-bronchodilator FVC less than 65%, enhanced exacerbation rates. I think that's a mistake there. People who had greater than 3 exacerbations had more of an improvement. Adult onset asthma, and also a combination of all those factors really gave those patients a much more remarkable response. We are now going to shift our focus to anti-IL-4 receptor alpha. There are 2 types of these receptors, the type 1 and type 2 receptors. Depending on the receptor type, it's either on structural or circulating constitutive cells. And you can see here that dupilumab blocks both the effects of IL-13 and IL-4. And anti-IL-4 receptor alpha therapy with dupilumab reduces exacerbations. That reduction in exacerbations is much more pronounced the more eosinophilic you are. It causes reductions in FeNO and total IgE, and transiently increases total eosinophils for approximately 4 months due to effects on eotaxin 3, which causes issues with eosinophil chemotaxis into tissues. Again, this slide is meant to highlight the importance of not only phenotyping the patient, but looking at markers that will determine enhanced response to treatment. You can see here there's a nice effect in patients who have the highest eosinophil count and high exhaled nitric oxide count. And the effect of the drug in terms of exacerbation reduction reduces as the presence of these biomarkers is lower. Next slide. Oral corticosteroids are very frequently used, and unfortunately, as pulmonary physicians, primary care doctors, pediatricians, we are quite good and at giving people oral corticosteroids. We are contributing greatly to the oral corticosteroids over prescriptions. And 3 million patients in the US fill at least 2 oral corticosteroid prescriptions per year. As a reminder from last year, oral corticosteroids can be quite toxic, and it only takes about 3 short courses of oral corticosteroids or 1.5 grams to begin to see long-term effects of oral corticosteroids. So we really need to be thinking about how to reduce oral corticosteroid use. Here we are trying to figure out what proportion of patients with both mild, moderate, and severe asthma have uncontrolled disease. And there are 2 ways to define control, as you recall. One is risk, which is the exacerbation frequency. And the surrogate for that in this slide here, published by Dr. Bleeker, presented by Dr. Bleeker at ATS, shows that patients who get more than 2 annual systemic corticosteroid fills are at higher risk of having exacerbations. And those are the patients, it's roughly 14 and 23% in the 2 groups. If you use annual short-acting bronchodilator fills as a marker of poor control, and here it's defined as greater than 3 SABA fills per year, the number of people who are uncontrolled goes up to between 28 and 39%. If you have either one of those 2, meaning you have either oral corticosteroid exposure or increased SABA fills, then your frequency of uncontrolled asthma in the US population really goes up to between 36% in GINA 1 to 3 patients and 50% in those in the GINA 4 to 5 category. So unfortunately, we are not doing a very good job at achieving asthma control with our current treatment of these patients. So how can we eliminate oral corticosteroid overuse? There are a number of approaches that can be used to reduce oral corticosteroid use in patients with asthma. One is to focus on OCS sparing. So reducing our resistance to using newer therapies like biologics in patients who are being exposed to frequent oral corticosteroid prescriptions, addressing modifiable risk factors, overdiagnosis or incorrect diagnosis, optimizing asthma therapies, referring patients to subspecialists or higher levels of care in a timely manner, and really focusing on oral corticosteroid sparing strategies. The other way to eliminate OCS overuse is OCS stewardship, and that is used in accordance with the latest guidelines. Try to use the lowest dose possible, taper as soon as possible, monitor use and adverse effects closely. For example, if you're giving patients a lot of oral corticosteroids, you should be checking their A1C. You probably should be checking their triglycerides and looking for hypertriglyceridemia, hypercholesterolemia. You want to figure out if they're developing cataracts or having issues on bone density. And so if you're prescribing these medications, you need to really look for these adverse effects and plan to intervene early by either not using as much oral corticosteroid and also treating the comorbidities that are occurring. And you want to also consider the presence of adrenal insufficiency, and there'll be more data, actually really interesting data coming out next year on this when you're weaning oral corticosteroids. the prevalence of adrenal insufficiency can be quite high. So you need to keep that in mind as well. We're going to use this rheumatology data to show maybe where we could be in asthma care over the next few decades. So you can see here, this is a prospective national biologics registry in patients with rheumatoid arthritis. And on the left, you can see the probability of corticosteroid use at follow-up visits. And over time, the level of the percentage of patients getting oral corticosteroids goes down, which is what we want to see in asthma care. On the right here, you can see that this was a consequence of two things. One was that the hazard ratio of starting glucocorticoids decreased over time. So people became a lot more conscientious about not using oral corticosteroids so liberally in this group, and likely intervening earlier with biologic therapies. On the other hand, there was also a higher hazard ratio of decreasing and eliminating glucocorticoids in people that had been on them over time. So you don't start it as much and you reduce it as much as you can, which results overall in a significant trend in the right direction towards reducing the probability of people being on oral corticosteroids. And I think we should adapt a similar strategy in asthma. I'm going to talk about what the biologic drugs do in terms of oral corticosteroid use. Here you can see mepolizumab significantly reduces oral corticosteroid dose while also reducing exacerbation. So you're getting both effects. Next, benralizumab similarly reduces the oral corticosteroid dose about 50%, at the same time reducing asthma exacerbations. Dupilumab similarly reduces oral corticosteroid use about 32% while reducing exacerbations. This really is a very busy decision tree. I don't expect anyone to go into much detail with it here. If you want to discuss this with me separately, I would be happy to. But essentially, the purpose of this is to highlight how I go about deciding how to pick a particular drug for particular patients. Essentially, I want to highlight two things here. One, you need all the information about the patient phenotype in order not only to understand if they qualify for these drugs, but to figure out if they meet thresholds and characteristics that may predict an enhanced response to one drug or another. Two, you want to then focus on whether they have corticosteroid-dependent disease, which will guide your decision-making in terms of what medications to start. And then lastly, you can use exhaled nitric oxide to sort of identify people who will have an enhanced response, particularly to IL-4 receptor therapy. There are some post hoc data now showing that high exhaled nitric oxide patients also respond similarly well to anti-IL-5 therapy. And lastly, if patients don't meet any of these criteria and you've confirmed it by repeating biomarkers, they may not have type 2 asthma. And non-type 2 asthma, unfortunately, is currently an orphan disease with not many good options. But we are hoping that in the near future that will change with some of the drugs that are being studied currently for severe asthma. Lastly, you want to focus on those comorbidities and you want to decide, is the comorbidity a predictor of response? For example, you have nasal polyps, you're going to respond more to drug X. Or are you trying to target that comorbidity with the treatment? Because in actual fact, type 2 disease can be quite systemic. Patients can have nasal involvement, esophageal involvement with esophageal eosinophilic esophagitis, and pulmonary involvement, or skin involvement with atopic dermatitis and pulmonary involvement. So you really want to think about these key issues. So you have to define a clinical response to biologic therapy. And basically, you're looking for exacerbation reduction. You're looking for OCS reduction. You're looking for improvements in asthma control. You're looking for changes in pulmonary function. Those are usually very modest and less likely to be present. You're looking at whether you can reduce inhaled corticosteroid dose and whether the side effects, affordability, and patient satisfaction are adequate. And you want to reevaluate the patients every 3 to 6 months. If the patient responds to the biologic therapy you pick, you would continue it. You would start to wean oral steroids and probably also wean inhaled corticosteroids in those people who have significant response. Consider adrenal insufficiency when weaning. If the response is unclear but significant enough to continue, you can continue the therapy for 6 to 12 months. If there's no response, you really need to consider switching treatment. Just a couple of slides on macrolides and we'll transition to COVID. Basically, macrolides reduce asthma exacerbations by about 40%, whether you're eosinophilic or non-eosinophilic, and it works in severe asthma. It also reduces the number of oral corticosteroid courses that patients with eosinophilic asthma were exposed to, and antibiotic courses in those who are severe or non-eosinophilic. A couple of things to think about macrolides. You really need to think about cautioning the patients about long-term hearing loss, and I usually send patients to audiology if I'm going to leave them on macrolides for a long period of time, more than 6 months to a year. You also want to get a baseline EKG, make sure there's no QTC prolongation at baseline and after at least a few weeks of therapy. And you really want to consider a trial of chronic macrolide in people who are exacerbating, and it's particularly effective in people who have those seasonal severe exacerbations related to recurrent viruses in the winter time, for example. So I'll now transition to COVID and asthma. I'm sorry, I'm going a little bit over, just a few more minutes and we can have some questions. As a reminder, COVID-19 relies on the ACE2 receptor and the serine proteinase TMPRSS2 for cell entry. So SARS-CoV-2 binds the ACE2 receptor, TMPRSS2 snips off that little spike protein, which is then engulfed into the cell, takes over the machinery, and starts to produce, to replicate the SARS-CoV-2 virus. Asthma actually has an impact on both ACE2 and TMPRSS2 expression. And you can see here in this publication from this year, they looked at patients with and without asthma, with and without allergic sensitization. And as you can see, patients with allergic sensitization had lower ACE2 expression in their epithelial cells. And here they were looking at airway epithelial cells. If you had asthma alone, you had a slight reduction compared to those without asthma or without sensitization. And if you had both asthma and IgE sensitization, you had the lowest level of ACE2 expression. And you can see that the degree to which you are sensitized in terms of your allergic sensitization decreases the ACE2 expression over time. And so the more allergic you are in the presence of concomitant asthma, the less expression of ACE2 you will have. IL-13 and other T2 cytokines are associated with decreased ACE2 expression, both in nasal and bronchial epithelium. You can see that patients here, when you treat bronchial epithelial cells and nasoepithelial cells with IL-13, you have a reduction in ACE2 expression. And the association of T2 biomarkers and nasobrush ACE2 expression demonstrates that if you have positive allergen-specific IgE, total IgE level, exhaled nitric oxide, blood eosinophils, or nasoepithelial IL-13 expression, all those factors have a negative correlation with ACE2 expression. There are distinct effects of asthma and COPD on disease expression and outcomes in patients with COVID-19. And here we are really looking at the expression basically of the ACE2 receptor in bronchial and alveolar epithelial cells, you can see COPD patients have up regulation of ACE2 expression, whereas patients with asthma have lower ACE2 expression than even patients without COPD or asthma. So what about inhaled steroids? At the beginning of the pandemic, everyone was panicking about whether to continue inhaled steroids or stop them because steroids may suppress your immune system, perhaps make you more susceptible. There were a lot of concerns about inhaled corticosteroids. This is a really nice study here that shows that ACE2 expression is actually downregulated in a dose-dependent fashion with higher exposure of inhaled corticosteroids. That also applies to TMPRSS2, so the higher the dose of inhaled corticosteroids, the lower the expression of both of these important factors when it comes to SARS-CoV-2 infection. The second figure B basically shows you that IM triamcinolone does not have a similar effect. And so delivering the drug straight to the epithelium is quite important with regards to reducing ACE2 and TMPRSS2 expression. The asthma prevalence in COVID-19 is much lower than with influenza, so about 22% of the patients admitted to the hospital with influenza have concomitant asthma, and you can see the prevalence of asthma in patients admitted with COVID-19 is much lower than that, on the average between 5 and 10%. So how does asthma impact COVID-19 outcomes here? First, we're looking at people who just test positive for COVID-19, and you can see that the patients that overall there is a higher odds of testing positive for COVID-19 if you have asthma. However, interestingly, those with allergic asthma seem to have a lower likelihood of testing positive than those with non-allergic asthma. Then you can move down to the severe clinical outcomes of COVID-19. Overall, it seems that asthma increases the odds of having severe outcomes with COVID-19. But if you look down into the allergic versus non-allergic asthma, it seems that this risk is really driven predominantly by those with non-allergic asthma. Next slide. Asthma causes increased risk of severe COVID-19. And again, here you can see a very similar story. If you have asthma overall, you have an increased odds of having severe COVID-19. But if you parse it out, the allergic patients appear to be having a lower likelihood of having severe COVID-19. And this is being driven primarily by non-allergic asthma. This is in a totally different cohort from the first paper, and those with concomitant COPD are even at more risk than those with non-allergic asthma. So what do we know then about asthma outcomes with COVID-19? It's not associated so far with the few publications we have that are limited because they're small cohorts. It doesn't seem to be associated with an increased risk of hospitalization, no differences in mortality. There is a higher risk of severe clinical outcomes when compared to non-asthma, and there is at least one publication that demonstrates prolonged duration of mechanical ventilation. What does Gina say about how to manage asthma in the age of COVID-19? You should encourage ICS adherence and treat acute exacerbations with short courses of oral corticosteroids. Minimize OCS use. Remember, nebulizers are aerosol generating. I always tell my patients, I haven't had very many with COVID, but the few I did, to use their nebulizer in a room where they are alone and to try to vent the room by opening the windows and to not allow other family members to come in the room for at least 1 hour in order to prevent that aerosolized virus from infecting other people in the household. And in the hospital, I know we definitely use much. We don't use nebulizers frequently in patients who present with asthma and COVID-19. You should continue your nasal steroids and avoid routine performance of spirometry. The other thing to note is that, in fact, it doesn't seem that COVID-19 causes asthma exacerbations very frequently, and most of our patients really presented with hypoxemia and pneumonia rather than wheezing and symptoms consistent with an exacerbation. So thank you so much for listening. I know I went over, but I'm happy to stay and answer as many questions as you may have. Thank you so much.
Thank you very much. We did have a few questions come in, and we encourage folks to continue to submit those. The first question was in regards to diversity trainings and offering culturally and linguistically appropriate services. And it looks like there has been a lot of helpful resources added to the chat. So I would encourage folks to look to the chat for that information.
Yeah.
Another question. What is your experience with smart inhalers, for example, Bluetooth enabled, allowing reminders for patients to take meds, but also to provide feedback to clinicians regarding adherence? If you have experience, do you feel it helps with adherence or decreases exacerbations?
Yeah, so this is quite a timely question because I'm sure some of you realize, and I don't know if you're having an inhaler talk this year, but about a week ago, the new digital inhalers came out. Teva Pharmaceuticals has released a Pro Air and the Air Duo inhalers that have a little digital piece at the top that will measure inspiratory flow. It'll timestamp when the inhalation was taken. It'll give you a nice little graph in the form of in their app that will basically tell you when the patients took the drug, what their inspiratory flow was, whether the technique was good because you require a certain amount of peak inspiratory flow to get the drug. And it'll also give you some ideas of other parameters. And so we are really at the precipice of finally actually getting some information. And the beauty of this kind of device is that the microchip is in the device. And so you don't have to add an extra dosimeter on top or other types of devices that you have to attach to the inhaler, which is a little bit more difficult. But what we can say about any of these technologies, either smart inhalers or devices that you can attach to existing inhalers, what we know is you learn a whole lot of information you didn't know when you use these devices about both adherence and technique. And that will really, we don't know how this will change, whether we can predict exacerbations and how well we care for our patients. But we are finally getting some tools that will be able to allow us to have insight. So, for example, if somebody tells you they're taking their medications, but they're rather non-adherent, you could re-educate them. If they, for instance, have poor technique, you could re-educate them and improve drug delivery to the lungs. And in the future, we are going to start a study here at the University of Michigan to see if we can use machine learning techniques to identify exacerbations early in the course and whether intervening early can actually improve outcomes for patients with asthma. So there's a lot to come on the digital inhaler space. And I think it's quite exciting to see. I don't know what the reimbursement is going to be like for these inhalers. I haven't tried to prescribe one yet myself, but I'm really looking forward to seeing this information.
Thank you. I have a question come in. How can we learn more about the long-term effects of corticosteroid use?
There are some publications that I can share with Tisa. I mean, I think what the best that we have currently is publications from groups in the UK and such that have very large data sets. A lot of these things are based on claims data sets where patients are followed for many years. So I will happily send Tisa some reference articles that she could share with everyone.
Great. There's a question about children with asthma have not shown that they are at more risk of contacting or having more serious COVID. Is that correct?
Mm-hmm. There's not a lot of data out there about kids. I pulled all the publications on asthma and COVID. Many exclude children or have very few children. Most of these were published in between March and July, when children, you remember, I think all of us remember when everyone said children don't even get COVID or they don't get sick at all. And so that we have a really gap in knowledge about how this disease affects kids with asthma. I don't think there's a lot of good data out there. The little that we see, it seems to be similar to the adults, but I think it's a real black hole right now. And I'm hoping in the next few months that we'll get some more information about children.
Thank you. And one last question at the moment. Are people who respond well to biologics expected to remain on them for a lifetime?
Yeah, that's a really good question. And frankly, it's the first question patients always want to know is, can you make me better? When they're better, they want to know, do I have to take this medicine now forever? So once you achieve the first goal, you have that second hurdle. The answer to that is we don't know. One of the glimpses into what this might mean in the future is a paper that I think is going to come out in hopefully soon. There was some presentation of it at a recent CHESS meeting. There was an abstract that was presented. Basically, they have a cohort of patients that had been on mepolizumab for roughly 4.5 years, and they randomized them to continuing or discontinuing. And interestingly, as would be expected, 2/3 of those people were not able to discontinue. So over time, the eosinophils went up and the patients started to exacerbate, went back on mepolizumab. But what I'm very intrigued by is the other 1/3 of patients that were able to stay for at least a whole year without an exacerbation. And what's unique about those patients? So these drugs are not disease-modifying drugs, at least that we know of at the moment, because they're very downstream. So you've already had the trigger at the epithelium, you've produced the cytokines, and now you're blocking the effect of the cytokines downstream. So we need to really start thinking of strategies to improve that, cut down that upper part of the inflammatory cascade. And there may be patients that are on these drugs for a long time that can be freed from them. What I do in my practice is if someone says, I really want to see if I can go without it, I begin to space out the treatment duration to see if they can be freed from it. Sometimes we succeed. So far, I've not had anybody that, got off and stayed off long term. So I think these are good tools that we have now. We may need, we just don't know enough to know for whom these treatments may be disease modifying and we'll be able to free them from biologics. It's a really good question and one, unfortunately, that we have very few answers to. But I think with a lot of large severe asthma registries, outcome registries, phase 4 studies, we will have more and more information about what happens to these people over time and whether we can get them off these drugs at some point.
Well, thank you very much, Doctor. It does not appear that we have any additional questions or comments. So I just want to thank you again for your time, and Tiffany as well. For the remaining attendees, just bring to your attention that an evaluation for the webinar has been added to the chat. We encourage you to complete that as you have time. And we want to thank everybody for their attendance today.
Thank you so much. Have a great day.
Thank you.